My name is Amit Garg. On behalf of the Enhanced Access to Kidney Transplantation and Living Kidney Donation investigators, thank you for listening to this talk on the effect of a multi-component intervention to improve patient access to kidney transplant and living kidney donation, a pragmatic cluster randomized trial. This trial was made possible by several organizations. Full results were published online November 3, 2023 in JAMA Internal Medicine to coincide with a late-breaking clinical trial presentation at the American Society of Nephrology meeting in Philadelphia. In the journal, there's also a nice commentary from Dr. Ebony Boulware, the Dean of the School of Medicine at Wake Forest University. The results are also discussed in a freely filtered podcast with guest Sue McKenzie, a kidney transplant recipient and founder of the patient support program used in this trial. I declare Astellas Canada provided support to produce education materials used in this trial. Declarations from other co-authors are in the paper. In terms of the rationale of this trial, we have a serious problem in kidney care. Patients with advanced chronic kidney disease have the best chance for a longer and healthier life if they receive a kidney transplant. And every 100 kidney transplants save the healthcare system in Canadian dollars $20 million over 5 years, primarily from averted dialysis costs. And yet, due to many barriers, many eligible patients today will never receive a transplant. Leaders in the province of Ontario, Canada, decided to address this problem. For context, in Ontario, advanced CKD care is provided by 26 renal programs managed by a government-funded provincial renal agency. Together, these programs treat 24,000 patients each year approaching the need for dialysis or receiving dialysis. Care is provided by over 3,600 nurses and nephrologists, and half of patients are transplant eligible. About 725 kidney transplants are done each year across 6 transplant centers, with 30% of kidneys coming from living donors. And prior to 2017, improving access to transplant was not a priority for the renal agency. Using a process described in the paper, a multi-component intervention was co-designed by a broad group of stakeholders to address several barriers which prevent kidney transplantation and living donation. These components were administrative support from a central operations group, for each program to establish a local quality improvement team to drive local performance and share best practices with other teams in monthly provincial rounds. Educational resources for health professionals, patients, and potential donors. Several were curated for use. And one resource, Explore Transplant Ontario, was created and mass-produced. A patient support group called the Transplant Ambassador Program, where past recipients and living donors voluntarily spent time in renal programs to share experiences and provide hope. And reports, which showed programs how their patients were completing different steps towards receiving a transplant, which were also discussed annually in one-on-one performance meetings between program leaders and the provincial renal agency. Leaders also agreed to generate robust estimates of the intervention effect in this pragmatic cluster randomized trial to determine if renal program-wide use of this multi-component intervention is superior to usual care in helping eligible patients complete up to 4 key steps towards receiving a kidney transplant. These 4 key steps, statistically analyzed in a multi-state model, were 1. Referral to a transplant center for evaluation, which in Ontario is done by a renal program after they complete required pre-evaluation testing. 2. Having a person contact a transplant center to begin living kidney donor evaluation, where patients with multiple potential donors only had the first one counted. 3. Being added to the deceased donor waitlist, and 4. Receiving a transplant from a deceased or living donor. In terms of the trial design, Both the protocol and statistical analysis plan were published before outcome analysis. It was implemented as a part of a learning healthcare system. There were no research coordinators at the 26 programs. It was published with patients and healthcare administrators as full partners, and it generated high-quality information at a fraction of the cost of a usual trial. It was registry-based, where baseline and outcome data came from healthcare databases. It used covariate-constrained randomization to allocate 13 of the 26 programs to each of the two groups. And it was approved by the Research Ethics Board to use waived patient consent, which meant all eligible patients who received care in the 26 programs entered the trial. To enter the trial, patients were aged 18 to 75 with no recorded contraindication receiving a transplant in our data sources, such as no evidence of home oxygen use, living in a long-term care facility, select cancers, or very high comorbidity. Patients approaching the need for dialysis received care in specialized clinics and had persistent evidence of an eGFR less than 15 or a greater than 25% 2-year predicted chance of receiving renal replacement therapy. Remaining patients entered the trial after receiving outpatient maintenance dialysis, either in a center or at home. And during the 4.2-year trial period, about 10,000 patients entered the trial in each of the two groups for a total of 20,000 patients, where half were approaching a need for dialysis. The analysis used an intention to treat approach. In follow-up, 1% of patients emigrated from the province, 1% recovered kidney function, 14% became ineligible to receive a transplant, and 17% died. These rates were similar between the two groups. Patients rarely crossed over between the two groups. In other words, patients spent 97% of all follow-up time receiving care in a program per the random allocation. And of interest, for the group approaching dialysis, 48% started dialysis during the trial period at a rate that was similar between the two groups. As shown in the paper, the two groups were well balanced on over 50 program level and patient level baseline characteristics. The mean age was 61, 38% were women. For those who entered the trial approaching a need for dialysis, the median eGFR was 16, and the median random urine albumin to creatinine ratio in milligrams per millimole was 162. And 1% of patients had a history of a prior kidney transplant. We observed evidence of intervention uptake. Each of the 13 programs established a local quality improvement team, developed a charter with their goals and activities, met regularly, and participated in monthly provincial rounds. Together, the programs reported over 1,700 patients completed Explore Transplant Ontario. The transplant ambassadors recorded meaningful interactions with over 5,000 patients with advanced CKD and 700 potential living donors. And each of the 13 programs received reports and met annually with the Provincial Renal Agency to review performance. As described in the paper, we observed no evidence of potential contamination bias, meaning programs in the usual care group did not inadvertently gain access to intervention materials. So here are the main results. Here we have the 4.2-year trial period in calendar months, and through this animation the counter will move right in time. We have the number of steps completed, standardized per 10,000 patients in each group who entered the trial, where the 4 steps again were referral, donor evaluation, waitlist, and transplant. We had the 2 groups. Patients entered the trial throughout the trial period, and after entry they were followed for a median of 2.1 years. The start of the pandemic, 2.4 years into the trial period, substantially impacted intervention delivery for at least a year. Quality improvement teams met less often, provincial rounds were paused, healthcare staff retired or were redeployed, and transplant ambassadors transitioned from in-person to virtual meetings. Referrals, donor evaluations, and transplants throughout the province were also delayed at this time. And so the trial began, and this is what we observed. There was no significant difference between the two groups in the rate of completed steps, with an adjusted hazard ratio of 1.0. Numerically, there was a higher rate of donor evaluations in the intervention group, with an adjusted hazard ratio of 1.22. However, the 95% confidence interval of this ratio contained a value of 1. As shown in the paper, we did not detect a significant difference between the two groups in different steps examined in isolation or in combination, in different subgroups, or in the rate of living donor transplants. The proportion of patients who completed at least 1 step, at least 2 steps, at least 3 steps, and 4 steps during the trial period did not differ between the two groups. So in conclusion, acknowledging the pandemic negatively affected intervention delivery, we failed to show this intervention increased access to kidney transplantation and living donation, which was disappointing. However, we are not giving up. We and others are deeply committed to addressing this complex and important problem. After much introspection, we believe aspects of our approach remain sensible. Co-designing solutions with diverse stakeholders, connecting health professionals in a community of leading practice, delivering patient and health professional education multiple times and in multiple formats, empowering past recipients and donors to share positive experiences with others, monitoring and reporting key steps towards receiving a transplant, and evaluating intervention effects robustly in a learning healthcare system. And so we are now completing a process evaluation to optimize our future approach, and some early data suggests better integration of different aspects, more healthcare resources for intervention delivery, better retraining for personnel who turnover, and making it clearer who is accountable for what may lead to future success. And so on behalf of the EnAKT LKD investigators, thank you for listening.